My name is Shaun Treweek. Great. So my name is Shaun Treweek, and I'm based at the University of Aberdeen. And I'm going to talk for probably around about 25, 30 minutes, something like that, which should leave us plenty of time for questions. And hopefully, if you have questions, you'll feel happy enough to ask them. I want to give you a little bit of background around something called the Include Ethnicity framework, introduce some other frameworks, and talk you through how you can use them, and hopefully that will give you some help, but also perhaps suggest some questions that you'd like to ask while I'm here. So let's see if we can get on. So if you're thinking about trials, or indeed any piece of health research, clearly we need to think about design. And research design is all about making choices. So from the very beginning to the very end of design, it's about choices. There are generally alternative ways in which things can be done. Sometimes it's very clear which is the best option. Very often it is not. But something that we, I guess, all know from our own experience is that often once a design decision is made, and you're going on with that throughout the rest of your piece of research, that there is little way back, or indeed no way back, from a bad choice. So if you have made a poor choice at the very beginning while designing your research, your trial, then that is something you're going to live with forever. And many of these, there's nothing to be done about it. You've made a mistake and you live with it. And for trials, and I'm going to speak mostly about trials, although I think a lot of what I say is highly applicable to other types of health research. For trials, a common place to make bad choices is around who is in the trial. And the key issue with regard to design and thinking about those choices is that if you make a poor design choice with regard to who is in the trial, and you make that choice early, that decision, possibly a single decision, can bake in inequality to that trial from which there is no recovery. You've baked in at the design stage an inequality, and no amount of statisticking later on is going to get you out of that hole. You've basically got inequality as part of your design. And that is something that the frameworks I'm going to talk about are intended to help avoid, hopefully mitigate, if not completely avoid. So I'm going to start talking about a few examples now of where design choices have led to what I and my colleagues, I guess, consider to be problems with regard to built-in inequality. So these are all real examples. Almost all of them are going to be very recent. This bunch of examples are around ethnicity. And the first one is linked to a National Institute of Health and Care Research funded, I was about to say smoking cessation trial. It's actually a trial that involved individuals who have already stopped smoking. And the idea of the trial and its intervention was to help those individuals remain as non-smokers. So it was to stop them reverting back to becoming a smoker. Now, if we were to ask ourselves, who smokes in the UK? Who are the people who smoke? And therefore, who are the people who, if we were trying to reduce smoking, we ought to be thinking about? The largest groups of smokers in the UK, if we use the Office of National Statistics categories, are individuals who would fall under the category of mixed and other ethnicities. Now, this NIHR trial, which was, as you can see, it's recent, 2022, its primary recruitment path was from an English stop smoking service, where fewer than 6% of individuals who used that service came from ethnic minorities. And those mixed and other categories, which are 20% or more in terms of the proportion of individuals who smoke, are largely ethnic minority individuals who do not use this English stop smoking service. So there's a single design choice the referral pathway, if you like, where they are recruiting individuals from, which means that it will be highly unlikely that this trial will be able to include and involve, and therefore gain the perspectives of and see what effect the intervention has, of individuals who form a very, very large part of those individuals who could benefit. So a single design choice has limited how inclusive that trial can be. And that choice having been made, in principle, you could actually add other routes. But that single choice means they're going to have a problem before they start. Straight away, there's a predictable problem there. We go on to the next bullet item now. This is around language criteria. And this, unfortunately, is not published, but this is colleagues Talia Isaacs at University College London led this. And she looked across 32, again, National Institute of Health and Care Research trials in 2 clinical areas, depression and diabetes. And what she was looking at is, are there criteria, eligibility criteria, within those trials around language? Essentially what we used to call, I was involved with this, we sort of, for shorthand, do we speak English? And over half of them had explicit language restrictions, and this is including trials linked to, say, talking therapies of depression too. So they were interventions which themselves were developed only for individuals who were judged to be proficient in English. So if those interventions proved to be effective and helped people with, for example, depression, then those interventions will only help individuals here in the UK with depression who speak English. And other work would show that a large proportion of individuals who have depression come from groups where language perhaps may well be an issue for them. And therefore, these interventions would be much less likely to be able to benefit them. And if we look to the last point, linked to those 24 depression trials, then the average proportion of white individuals within those trials was 92%. And that's an average. So sometimes it was a bit lower, sometimes it was much higher. And I guess the question we would ask is, do we think that on average, individuals here in the UK who have depression, 92% of them are white? And that is not the case. So those decisions around language, in this case primarily, and effort to involve others within those trials than white British individuals, means that whatever evidence comes from these trials is likely to only be, or mostly be, applicable to individuals who are white Brits and have good skills in English. And the worry with that is that we might think we have developed treatment to support depression for all of those with depression, when actually we have not, because we have not considered within our trials individuals who have disease burden, but are crashing into some of these other problems that we have set within our trial, in this case, language. So to a few other things. This is a bit older, this review. This is a US review. I don't know whether you mentioned earlier on about the term racial and race. That's something used more often in the US. Here in the UK, we would steer away from that term. But this is, I'm using their words here. And they were looking at groups found within trials which informed guidance produced by the American College of Cardiology and the American Heart Association. And the thing I'm highlighting in orange here is that across this review, that included here 814 trials. So not 10, not 20, not 30, but 814 trials. The average percentage of women who were involved in those trials was 30%. And again, we would ask ourselves, do we think that of individuals who have cardiovascular conditions, that women only form around about 30% of those people? I guess we would doubt that. So again, there's something about the way these trials have been designed, which has meant that on average, it's a much smaller proportion of women who are involved in those trials than we might expect, even without doing some digging into things like prevalence of particular conditions amongst different genders. So again, it suggests something's not been thought through appropriately. And then this is the last of my examples. This is a more recent review done by a colleague, or led by a colleague called Vicky Shepherd, University of Cardiff. And she's very interested in cognitive impairment, and we'll hear a little bit more about Vicky later on. And in Vicky's review, she looked across a number of clinical areas, and I've highlighted one here, which is hip fracture, and found that there were frequent exclusions of people with cognitive impairment across a range of clinical areas where you might think some of those individuals who have those conditions will also have cognitive impairment. And the one I've flagged, as I mentioned, hip fracture, what Vicky found there was that just over 80% of trials around hip fracture explicitly excluded people who had cognitive impairment. And the last sentence there is the key one. A third of individuals who have hip fracture also have cognitive impairment, which means that that single choice, if you have cognitive impairment, we are not going to include you in our trial, means that a third of individuals who have hip fracture will not be known to be benefiting or able to benefit from these interventions, because we have not taken their perspectives, their views on acceptability, their ability to engage with the intervention. We have not considered any of that because we've excluded all of them. And that's a third of all the individuals who have that particular condition, hip fracture. So that, again, on the face of it, even if we're not doing lots of digging into that to me sounds odd. Why would we exclude such an enormous proportion of those who could potentially benefit in a single design choice? And having made that choice, for example, it is now very hard to say something about individuals with impaired capacity to consent once you finish those trials, because they're not there. They are not in your trial. If you were asked by a member of staff who worked in a care home, will this intervention work for the people I have responsibility for in this care home, many of whom have impaired capacity to give consent, then those trialists would say, well, we don't know, because we excluded all of those individuals who had impaired capacity to consent. So this is why thinking about equity, diversity, inclusion at the design stage is so important, because it can make the results of your research much less useful to some groups who are very important constituents of those individuals who have the condition of concern. Now, I've just talked about a few groups. There's a long list of other groups if you wanted to, and it won't be exhaustive either, but NIHR has this list. It's at that link. So the point of, you'll see if you were to look at that link, is there are lots of groups who have historically been underserved by health research and are underrepresented in the research, and I would argue in guidance and the treatment that follows. So what my message here with this part of the talk is, researchers like me have traditionally thought more about how many people should be in a trial, which is important, but they have focused exclusively on that rather than who should be in our trials in the way that I've been mentioning a moment ago. There are characteristics about individuals which are important, and often some groups are excluded more or less explicitly by particular design decisions. NIHR, I've mentioned them a few times. They, 4 or 5 years ago, started to recognize that this was a problem and set up an initiative called Include. And myself and colleagues teamed up with NIHR to develop something called the Include Ethnicity Framework. And the idea here was to try and help trialists, and potentially other researchers, but trialists in particular, avoid some of those design faux pas that I mentioned a moment ago with regards to ethnicity. So the Include initiative itself is quite general. What we wanted to do was to produce something that was much more operational. Ask these questions. What you get out of the answers to those questions should directly inform your design. And a picture here, a bunch of us got together. There were more people on this than are on this slide. And it was a series of consultations that led to the development of this framework in 2020, or we finished it in 2020. And the framework itself which some of you might have had a chance to look at. If you haven't, you can get it at those links in the code. But the framework itself is essentially a two-part tool. And it has, as the first part, some key questions which are really to get you thinking. I'll show you those in a moment. And then I actually find it hard to answer those questions without more help. That's where the worksheets come in for 3 of them. We'll maybe mention the 4th one that it doesn't really help with in a little bit later on. But the 4 key questions, these are the sort of to get you thinking. And the top one, which sounds trivial and obvious, who should be in the trial, is actually really quite hard. And the worksheets that I'm going to show you in a moment don't really help with that. And we'll come on to that. But before you can do anything, if you like, about thinking around what do we have to do with our trial design or our research design to make sure it's inclusive, is you need to know, who do we need to include in our trial? Who are the most important groups within society, given our intervention, given the disease area, that we must include in the trial? So that's the first question. Who's in the trial? Who are the people you need to target? And then there are these 3 following questions. The first one is, okay, so we've identified those individuals, these groups. Is there something about the treatment area that, and let's say for argument's sake, it's hip fracture, as we heard earlier. Is there something about hip fracture that means that individuals in the groups we have identified, let's say it's white British people, Polish individuals and African Caribbeans, just to choose some groups. Is there something about those groups that mean that because it's hip fracture, they will respond differently? They'll be more or less willing to engage with a trial or piece of research in that area? That's the first of those questions. And the next one, question 3, is there something about the intervention itself that will make it hard for those groups we've identified to be involved? Is there something about where we're doing it, or how we're doing it, or who is delivering it, or indeed the form of the intervention itself, which means it will be very difficult, or at least more difficult for some groups to take part in our trial? And finally, what about the design itself? Are there some things that we are proposing within the design, where we're running it, how often we bring people in for measurements, the fact that we bring people in for measurements rather than doing it remotely, the things we are measuring, these sorts of things, do they too make it harder for some people rather than others to take part? And those 4 questions are intended to get you thinking. I actually find questions 2 to 4 in particular to be hard to answer without a bit more help. And that's where these worksheets come in. So those first 4 questions, they're the headline questions. And then there's much more detail in the worksheets for questions 2 to 4. And what these worksheets boil down to is a series of questions. And those questions we developed in consultation with a lot of people in iterative stages. So I am pretty confident that these questions all tap into things that are very important when thinking about the involvement of different ethnic groups in a trial, and potentially other types of health research. And we involved diverse ethnic community members too in these discussions. So I'm pretty confident about the questions being important for teasing out what we need to think about with regard to our trial design, or indeed potentially other health research design. So I've got a few examples just to give you some ideas of how you might use these frameworks. And the first thing I'm going to show you, this is linked to COVID. So we actually got some COVID funding back in 2020 to finish off the last bit of work for the ethnicity framework. So we have quite a few COVID examples which were done as part of that. And you'll see here one little snippet, and it's about disease severity, and then something about presentation. So the thing on the left, that column on the left, where it's the top one says, how might the severity of the disease vary between each ethnic group? That is a question in the worksheet. The stuff on the right is my response, or indeed our response. There's a group of us did this. And that response is done largely by searching the literature. Google, to some extent as well, trying to see, okay, well, what do we know about the severity of disease between different ethnic groups for our disease, or in this case, it's COVID. So given that, what do we know about the severity of disease? Now, I guess we're all familiar now with the idea that there have been disproportionate effects of COVID on different ethnic groups. So in our response here, we'd be thinking, well, there are differences across different ethnic groups, and therefore any treatment which is intended to, for example, reduce mortality or severe disease, for example, because there are differences in ethnic group by mortality and severe disease, it would be important then that our trial include individuals from those groups so that we can say something about the effect of our treatment on individuals for whom perhaps the mortality is greater or disease severity is greater. So it's important to think about prevalence or severity, rather, is what we're talking about here, severity of the disease, and make sure you do things in your design to enable those individuals to take part, because they are an important group of those individuals who have this particular disease. And you'll see something in brackets there. I just wanted to flag that up too. And we wrote this in sort of mid 2020. In the presentation of COVID in 2020 and the differences between the impact of COVID on different ethnic groups, the presentation, or my perception of the presentation, for example, in the media or perhaps even amongst science people, was that it was a bit of a surprise that there were differences in severity by ethnic group. And if we were to look at SARS-CoV-1 rather than SARS-CoV-2 COVID, exactly the same picture was seen. So when we were doing these forms, these frameworks in 2020, so in the height of COVID, it was clear from doing the forms that we would have been suggesting that it was important to improve diverse ethnic groups within the trials, vaccine trials, for example, because it was likely that COVID would be similar to SARS-CoV-1, which also showed differences across different ethnic groups linked to chronic illness as well. So it wasn't a complete surprise, I guess that's what I'm saying, or it shouldn't have been a surprise, because it's similar to what went before. And these forms, this framework can help pick up that sort of thing as you do it. It's not something I'd thought of before doing this. As soon as you start doing it and start looking for data, you start to think, actually, I think it would be important to involve these groups. And that last point there about how the disease might present for COVID, it seemed to generally be at that point we filled this in that presentation was similar. So that's not always the case. Some diseases may present differently in some groups, but in this case, it was similar. So the way this form is completed, the framework is completed, is looking at the literature. It's not a formal literature review, although if you found one that was relevant to the question, that would be brilliant. It is really, what can we find? What data are available to answer that question? What experience do we have within our trial team or our research team that might be able to provide some insight in answering that question? And you note it down. That's how we answer the questions. Here's another example. This is a surgical trial. And this particular question is linked to eligibility criteria. This surgical trial is about bariatric surgery. And the thing we're flagging here is the key criterion for taking part in this trial is the individual has to be referred for bariatric surgery. So the question I would be then asking is, how do people get referred? Because that referral decision is a potential route for inequality. What do you have to do to be referred? Who makes the referral? What are the criteria they're using? And as you'll see here, we note that there are different criteria for Asian individuals. So there have been some adjustments linked to body mass index, which is known to be different by ethnicity, or at least Asian ethnicity, so the criteria change. But there's also this comment here about a tier 3 obesity program. And that our sense was that that program, it wasn't entirely clear to us what that required. But what we're flagging here is that the requirements to attend, if you like, and consider elements within that tier 3 program may affect some groups more than others. In other words, it's something about a tier 3 program which must be completed prior to entering this trial. If some groups are unable or unwilling to engage with that tier 3 program, it means they will not be represented within your trial. And it's to do with the referral process, not your trial, the rest of your trial, if you like. Your intervention may actually be something that's very relevant for a wide range of groups, but that particular referral route will exclude potentially some groups more than others. So our point here is that there is a referral pathway. The impact of that referral pathway on inequality is unclear. It might be fine, but there is a route to inequality being baked in. And there's also within that trial a criterion we're flagging up at the bottom called committed to follow-up. So an individual potential participant must be committed to follow-up. Now, I can guarantee there is nothing in the protocol or any other part of this trial that explains how that is operationalized. So that means it's down to judgment. And that anything that is down to judgment like that, conscious or unconsciously, may exclude some individuals. So we would generally say criteria like that must be willing to follow up, must be considered by the clinician to be able to take part. Those sorts of criteria are very, very open to conscious or unconscious bias with regards to which groups, in this case, ethnicity, which groups are involved. So we would try and avoid those or suggest operational. How is somebody going to make that judgment about commitment to follow up? Exactly, so that it is applied in the same way to every single potential participant. So those criteria, these vague criteria about must be willing to do something or judged to be something, very open to problems, really, we would say. Okay, so this is another one. This is dental, another example. And this is now thinking about the intervention and how the intervention is delivered, in this case, mode of delivery. Are there things about the way it's delivered? And again, this is looking to the literature, spending time with Google, if you like. What do we know about how the mode of delivery in a trial like this might influence who can take part? So things which were flagged up by the individuals who completed this framework, which was not me, but would be around that, well, this is face-to-face. It's in a dental practice. And there was evidence from qualitative work that women who are Pakistani would prefer to see a female dentist. However, if they had to see a male dentist, they would prefer that person to be indigenous rather than somebody from their own community. So they preferred somebody who was not Pakistani if it was a male. So from outside their community. And that is something I've seen in other trials too. And the last one is around Chinese individuals who actually, they preferred somebody from their own background, and they're possibly linked to communication problems, language issues. So that face-to-face delivery is suggesting that there may be reasons to believe that some groups in this sort of dental trial would have challenges unless these issues are considered. Okay, so again, the framework has flagged them up as potential problems, and now to the trial team saying, well, what could we do about that? And if we found that Pakistani women are an important constituent group, then we would need to try and do something to address these potential concerns. This is the last example. This is a breast cancer trial. It's actually about reducing pain after breast cancer treatment through physiotherapy. And this is asking the question, how might the disease present differently across ethnic groups in terms of, for example, symptoms or patterns of disease? And we looked for information. What we really wanted were data about shoulder pain, which is what this is about, shoulder pain after breast cancer treatment by ethnicity. And our take home, which, and you'll see we mentioned at the bottom there, 2014 systematic review. Our take home message was that within a review of post-treatment shoulder pain, there is no mention of ethnicity in its findings. So in other words, we don't know. We do not know how the disease may present differently, or what its prevalence is, if you like, by ethnicity. And that, I think, is also as a learning point for all of us when filling out or trying to answer some of these questions. That is not uncommon, that the answer you're looking for, the data you need, are not available or not easily available. So in that situation, you're likely to be leaning on your clinical experience, or the clinical experience available to you within your research group, or trying to, well, we'll come on to that in a moment, but trying to be inclusive by default. So we don't know whether there's a difference, so therefore we have to be inclusive, because there may be a difference. It's just that we're unable to demonstrate it. We can't rule it out, and therefore we need to be inclusive. Now, I'm going to just highlight a couple of other frameworks. So there are two which have been developed, which are explicitly include frameworks, one on socioeconomic disadvantage, one on impaired capacity to consent. So it's just chiefly just to flag that these frameworks also exist. So it's not just the ethnicity one. So these are colleagues Heidi, Katie, and Fran, who led the development of the socioeconomic disadvantage framework, asks similar sorts of questions, but has structured it around something called the 3 Ps from the UK government child poverty strategy. So they would ask their questions and ask, what impact does this have potentially on things linked to pocket? So if a person is on a low income or is unemployed, what does your design decision mean for them? That would be a pocket indicator. If those prospects is if they have literacy problems or health literacy challenges, what is your design implying or likely to impose on them? So that's what prospects around the place is clearly linked to where people live. So if people live very rurally and you're trying to bring people into a central location multiple times, then that clearly has implications for them, with not only place, but I would guess pockets in that case, the cost of getting there. So it's a similar sort of set of questions, has the same sort of aims, but now it's thinking very carefully about people who are experiencing socioeconomic disadvantage rather than the focus on ethnicity. And then the third of the frameworks is one that Vicky Shepherd, and I mentioned Vicky at the beginning, on impaired capacity to consent. And again, similar sets of questions in principle, but now focusing on what are the implications of your decisions linked to your trial, health research, for involving individuals who have impaired capacity to consent. And Vicky's aim with this really is to try and increase the proportion of all trials, not just trials that may have a focus on individuals where impaired capacity is very central. So if you're doing trials in dementia, for example, it would be reasonable to think that you need to do something about people with impaired capacity. Vicky's aim is to try and help all trialists, irrespective of their trial and clinical area, to think about how might we best involve people with impaired capacity to consent, because they are a group routinely excluded. A lot of resources at that link that Vicky has prepared, so there's a lot of support available for that particular framework. And we do have on the Trial Forge site a lot of information to support improving trial diversity. So for example, I showed you a few examples linked to the ethnicity framework, which were taken from completed frameworks. We have 23 completed frameworks across a range of different clinical areas there. So if you're wondering how to answer some of the questions, there are a lot of answers for a range of clinical areas available at that website. And Vicky also has a lot of resources. We don't have quite so much for the socioeconomically disadvantaged groups just yet. So there are some support resources there. I'm coming towards the end of the talking bit, and I just want to flag a few other things before we end, and then hopefully we have a good bit of discussion. Data collection. So what this means is if we know that we need to include different ethnic groups in our trial, then we need to identify the ethnicity of each of our participants, and that is not as easy as it sounds. So some of the questions we have, or points we raise here. So what do you need to collect? How do you collect it? What do you tell participants, particularly about why you are collecting it? What do you tell participants about what you're going to do with it? What are you going to do with it? Those sorts of questions have come out as being very important to answer in this particular project called Included. And that's also on the Trial Forge site. So in that list of diversity help, you could get to some results from Included, which give guidance on how to collect ethnicity information. And I think some of that would be relevant for other types of information. And one that jumps to mind immediately, or one element of that is drop-down lists of ethnicity. Nobody likes those. So if we're asking about the ethnicity of participants, then almost every time you ask diverse ethnic groups about how to collect ethnicity, they would say free text, allow us to self-identify. And I suspect that also applies to some other characteristics. For example, sexual identity would be one, gender, probably another. So some of these ideas are likely to also be of relevance to other characteristics. I mentioned when I was talking about the frameworks that first question, who should be in the trial, is far from easy. And it's one of the hardest questions to ask. Sorry, it's easy to ask, hard to answer. And the frameworks, what they often do, there's a second challenge for us, is that they often highlight problems, but don't always suggest a solution. And the project I'm flagging here helps a bit. And that's also on the Trial Forge site. But it gives some clearer steer, if you like, with regard to ethnicity. If you find that you have no time to really go into any sort of depth for your particular trial, you might lack the resource, there might be some other constraint on the time you have to put into this, then what fell out of that project was that the minimum target for involvement of ethnic groups should be the proportion as found amongst the population of people with a condition targeted by the trial. So you could shortcut straight to that if you wanted to and think, okay, hip fracture, how prevalent is hip fracture by ethnicity in our region? And then that's what your target would be for your trial, so that it represents those who have the condition of interest by ethnicity. That sort of fell out of that work. It wasn't actually something we intended to, a sort of recommendation we intended to get, but it came out naturally. And then what that group also recognized was these data don't always exist, or you can't obtain them. So they then said, well, okay, in that case, a trial group with very restricted time might then say, well, okay, we will involve in our trial ethnic groups at the same proportion as is found in the most recent census data for the area where we are doing the trial. So get it as granular as possible, and that would be our minimum. So we will aim for that because we don't have the time, the resources, the skills available to us, or the data. Perhaps we have other things, but we don't have the data. So this is as good as we can do. But there should be some target by ethnic group that is based on some data, in this case, the best, most granular census data that are available. So this is the last slide, just to summarize then. So what we have thought from all of this sort of work is that all of us need to think explicitly about who needs to be in the studies. It's more than the number of participants, and it's more than clinical criteria as well. If somebody has a particular diagnosis, it's really about the characteristics like age, gender, sexual identity, ethnicity, those sorts of characteristics that we're really thinking about there. And I think I heard just before I started Darcy saying about listening, and this would be something we too would strongly recommend for this, is that researchers like me need to involve people who are like the people the trial needs, and we need to involve those people in design. Trial teams themselves, for example, need to be more diverse in general. So we need to listen to what people who are like the people we need to involve say to us about what the design needs to look like. We think the frameworks can help, we think, but we need to evaluate them to a greater extent. So I wouldn't put a sort of evidence-based stamp on them as being a guaranteed effective way of designing an inclusive trial, but I think they can help. Hopefully over time, we'll start to improve our confidence with regard to that more rigorous evaluation. And the last point is essentially emphasizing that it's hard, and that the evidence available to trial teams and other researchers to do effective inclusive trial and research design is actually quite limited. So I think all of us need to recognize that and then do what we can to try and improve that situation. So there is more concrete material and resources and guidance and resources to help us do inclusive research design. And that was the last slide. So thank you very much. I'll stop sharing now since the slides have finished.
Thanks so much, Shaun. Just checking how you can hear us without the mic. Have you got good?
I can hear you very well. So I don't have any
well.
problem at all hearing you.
So and you're open to questions now. We can try without the mic, and if we just need it so everyone can hear the questions, we might bring it in. So the floor is open. Me?
Should I go for it?
Yeah, please do. Yeah.
Hello, hi, thank you so much. Very interesting. I like a couple of points you made. One was about the census needs to kind of be the target for minimum with the ethnicities. That was quite good. And second thing, I was kind of curious because you said that the Pakistani community women said they wanted to see somebody from their own ethnicity into the dentist, but not from the same kind of country, like I don't know, they got similar language or something. So that was quite interesting. I mean, it's good. It's kind of one way good that the communities are moving forward. Because I remember in the 80s, there was almost kind of this racism that if you were white, you were more professional than somebody who was Asian. So they wanted to see a white doctor, which was very bizarre, but moved away from that. But where I'm going with this is that how do we kind of change, what can we do to change the mindsets of people that it doesn't matter if somebody's from your background, they still respect confidentiality, because I think there's a lot of insecurity around what if they disclose my personal details to somebody in the community that they know.
Yeah.
So I just want to hear
so I think that's a very good point. And I guess the direct answer to your question as to what can we do is I'm not sure. I think that my starting point would be to ask individuals who are like the individuals that we would like to involve for their views of what essentially concerns them about, for example, who is asking that question. And I know sitting in the room is Shoba Dawson, who did a really nice piece of work for us in the lead up to a trial on in vitro fertilization, where we, in that trial, knew we needed to involve Asian women, and the Shoba organized some work with public contributors to get some views, because it wasn't an area I knew anything about particularly. And one of the key findings from that was that those women would like the trial to be introduced to them by a woman, and that I sort of expected that. But what they also said was by a woman who was not Asian, not from their community. And that was because of a fear, the points you were making about trust and confidentiality, but they had a fear that their infertility, or indeed it may not be their infertility, it might be their partner's infertility, but what they were saying is that the perception would be that it was their infertility. They did not want that to leak out into the local community. So they would be happy to talk to a woman, but they wanted that woman to be of an ethnic group other than their own. And that was not something I expected, reflecting my lack of insight into the perspectives of that particular ethnic group for this particular condition and the particular intervention we were thinking about. So I guess my starting point there would be we would have those conversations. It often throws up things that, which for me, coming from a different community, was unexpected. And then we would do what we can to respect that. I think we may not, that trial did not get funded, so we never actually had to try and address this. But I guess we could, as you were suggesting, think, okay, well, we may have a challenge here. We're going to have to emphasize in a way that is likely to be trusted that the information you give us and this discussion will be completely confidential. Here are the guarantees we can give you. This is why it will not find its way into the local community, for example. You have every reason to feel reassured, and we probably have to find somebody who was not for example, me, who would provide that reassurance? So who would they trust when being told this is confidential and this is what you can expect and this is why it won't? So I think there's it requires careful work to develop solutions which are trusted. And I think the bit that the frameworks do is throw up problems. They don't always throw up solutions. So I think this one, we identified a problem. We never actually had to address that particular problem in that IVF trial because the trial wasn't funded. But it would certainly have been something around trust and possibly being able to have an alternative, perhaps central point where people could have those recruitment discussions in a way that they felt was more safe for them. They felt their confidentiality was being upheld. It would have been something we'd had to deal with explicitly. Case by case, I guess is how we do it. But trust is very, very important. And I think we'd have to do that trial by trial.
I'm really pleased that you mentioned trust, because I think that's the problem. It takes years for a practitioner to build a trust, but only a few minutes to lose it. And I've seen some really bad practice where people have lost trust in practitioners.
Yeah, agreed. It's, as you say, it takes a long time to build it up. It's very quick to destroy it.
Yeah.
Any more questions?
Yes. Hi, Shaun. Thank you for a brilliant talk and brilliant work. I guess I'm interested in the adoption of Include and frustrated by the number of conversations that I have where it just hasn't been thought about at all. And I'm just wondering about, I'm thinking about sort of motivations and drivers of change in the research community. And are there any examples where a process has been built in to a research system or a research setting that has kind of really made a significant change? So in the way that we would, for example, go to an ethics review committee or have people peer reviewing grant applications. Are there examples where this has been taken up in a more sort of systematic approach?
There are some on the cards. I think you're right to identify a challenge, which is uptake. So there's stuff out there. What we obviously want is for it to be used. And I think there has to be a sort of carrot and stick approach. So I think it's important to highlight why this is why we need to think about inclusion. So the examples I gave, that sort of like we can easily make mistakes if we don't think about it explicitly. And it's important to provide some tools that can help. And we're moving in that direction. So let's say carrots. There are some things that can help. The initiatives there are two initiatives that I can think of immediately. Shoba, who I know is sat in the room, is involved with one of them, which is, for example, we are having conversations with the National Institute of Health and Care Research to make consideration of inclusion more systematic within the grant review process. And I guess that's both peer reviewers and panel review. So I don't know where that will end. It might go very far and end happily for us, or it might not. But it's to recognize the issue that you raised, that can we make something more systematic so that it is always considered and that it is not possible, or at least much less possible, to have a piece of research that is not considered inclusion at all or sufficiently. And that, we think Shoba too, requires a systematic approach. There has to be something within that approvals process at the funder end to try and make it less likely that inclusion will not be considered. So that's the first thing. And then the second thing is, so that's the first point, but there are other places where we could catch it. And you mentioned ethics. So another initiative that I know is happening, because I've been a little bit involved with it, is linked to work being done by the Health Research Authority and the Medicines and Healthcare Products Regulatory Agency. And they, as part of their approvals process, are developing something called a diversity plan. So the intention is that applicants for approval from either the Health Research Authority alone or HRA plus MHRA would have to submit a diversity plan. And that diversity plan asks questions which are broadly similar to those 4 questions that I mentioned in the include framework. Who's in the trial? What are you doing to try and involve them? What measures are you taking? How are you monitoring it? How do you know it works? So those sorts of questions. And the intention there is that it would be entirely possible that you would have your application to the Health Research Authority rejected, so you would not have your submission approved on the grounds of your diversity plan being considered to be inadequate. And similarly, for the MHRA drug trials, they could make the same decision, or more likely both together. So that again would be another opportunity to make systematic this consideration of inclusion for each individual, not only trial, because it's involving the HRA now, but health research in general. And I think that's a positive step, as long as we are careful. And I know both HRA and MHRA are going to have a sort of soft release of that. So it's hard. That last bullet point I made in my summary is that trial teams, research teams often can't find resources that will help them to ensure their trial is more inclusive. So expecting people to suddenly be able to do stuff that we haven't been doing very well for a long, long time is unrealistic. So we're moving in a direction, I think, which is very positive. I think bits of our research infrastructure are working to make it more systematic that inclusion is considered, and we're looking for measures to improve it. But I think we all recognise that we have to be a bit mindful of how hard it is to move from where we have been to where we would like to go, because we don't have an enormous amount of evidence-informed initiatives and strategies and approaches that we can say hand on heart, well, if we do this, that will really help us to effectively involve people who are suffering from socioeconomic disadvantage at present, for example.
Yeah, we'll go here and then here.
Hi, thank you so much, Shaun, for your talk. So I work across the university trying to coordinate the ways in which people work with different communities engaging in research. And something that we've heard from communities whilst we've been developing a strategy across the university is that if you are a community from a particular group that researchers are often trying to reach, that you can be very, very saturated with requests. And the researchers tend not to know anything about any of the other researchers that have reached that community. And the researchers or research teams don't tend to have a sense of the broader context for that community. And I think in part that is because things like their literature review, they have to review the data around the health condition or around the science, but they don't have to review the context for that specific community. They don't have to look at, like, has that community engaged with similar research 5 years ago that hasn't since done anything? Like, there's been no result from that research. So I feel as if, well, I'm curious as to if, because obviously this stuff is super helpful for individual trials, but is there any work being done, a bit like the previous question around a systematic approach, to kind of look at how it coordinates across the piece and how researchers can be more incentivized to have that and to also relationship build? Because another thing that we see is that funding applications for participatory research tend to go straight into, we'll have a PPI group, and you're like, okay, well, it's going to take you a few months to build the relationships to enable the trust to do that. And so do you have any thoughts about that kind of more coordinated and systematic approach that looks at the context communities are living with?
I guess some, but probably nothing like as well formed as we all need. So some of the stuff we have been involved with through Trial Forge to get the trust side of things in particular, we have tended to, or very often tended to, go through a third party. So we ourselves have not gone direct to community organizations, and my own personal work has been mostly around ethnicity. So we have involved another group. So the group I'll name is Egality Health, which is a small company that is focused on working with ethnic community organizations. So we have gone to them because they have that relationship that's ongoing. They know the research that those organizations are working with them on, and indeed what they are working on, but not with Egality, so because Egality has this ongoing relationship. And they navigate the relationship, if you like, between the researchers, us, and the community organization. So we tend to go through an organization like that because they have ongoing relationships. It's much less transactional than the researchers sort of bouncing in a year apart, asking questions that somebody else asked last year. So I think that's an approach which has worked well. Certainly from our perspective, I don't get the impression that we are wasting community members' time in that way, but how to capture what lots of researchers are doing in that more systematic way, so that we perhaps don't have to go back at all, because we've actually answered it collectively as to how best to involve particular groups or how to think about involving particular groups. I think that's more ad hoc, and again, that's just positions as it shows that we're positioned very early on a pathway to being more effective at working with groups we have traditionally not worked with. So we are, for example, within the STRIDE project that I mentioned during the talk, trying to collate information that we have found from, for example, those include frameworks we did, so that if we were wanting to involve, let's say, African Caribbean individuals, well, what do we know from those frameworks about things that we would need to think about when designing a trial that has identified African Caribbean individuals being important? Because we do know something from those frameworks and potentially other bits of public work that have been done to date. So we'll do a little bit of what you want, I think, in STRIDE, but we won't do entirely what you want by any means. So I agree. I think some effort to aggregate information and also maintain relationships with organizations that goes beyond individual researchers is important. There's some sort of infrastructure around it, and NIHR, to their credit at least, have funded a piece of work that is looking at, again, this ethnicity that I'm involved with, looking at how to what's the blueprint for doing that, not to develop it, but what would you like us to develop? And that is working with diverse ethnic community organizations, and that will address in the blueprint, I hope, some of the problems, or highlight some of the problems you highlight about lack of a systematic approach to collecting that information, so that we don't keep going back asking the same thing over and over again, and that we don't record what we already know.
Thank you. Can I just very briefly add that in the university strategy that we're creating, one of the things we're trying to do to improve this is to have kind of structures that exist beyond individual researchers, that researchers can kind of come in and out of, but the relationship continues. So if anyone has any thoughts on that, because it's very early days of thinking it through, I would really appreciate like a conversation at some point. Thank you.
Yeah, I think that's a great idea, because individual researchers, transactional is the word that people have used to me, and it annoys people. So the ongoing relationship need not be with individual researchers, but with some other part of, let's say, the university or the research, national research infrastructure. So I think your approach is very sensible.
And then we'll go to Shoba.
Thank you for your talk. I arrived halfway through it, but thank you so much. My question goes to undergraduate research, which is where we are sort of training people to become researchers, ethical researchers, people who are inclusive. But I also, in my other life, review a lot of undergraduate research, and the number one thing that I find there is we will exclude people who cannot speak English. And this is something that is approved by departments, by supervisors. That's the standard. So I then ask myself, well, if we are training them at 23 to just say, well, if you can't speak English, you can't be part of my study, then we expect them at 46 to now, include everybody, it's sort of, I don't know, when I always look at it, I always think, well, these are the same people that we then encounter a couple of years down the line. They want to become PIs, and now you start saying, well, you are supposed to include everybody. But you're the same professor who trained me before that if they can't speak English, I'm not supposed to include them. It's okay not to include them. So I think like she was saying, some of these things should happen right from the beginning of how to train a researcher to become one. And I think one of the issues talked about from the HRA, from the NIHR perspective, where they're trying to groom researchers right from the bottom, because then they catch them most of the time as fellows and masters and upper levels. But at the bottom level, we've already trained the basics that if they can't speak English, well, don't bother, Yeah, so that's just something that came up in another meeting.
Yeah, and you're absolutely right. And my colleague Talia Isaacs in particular has been making that point for a long time and hard, that it's very common. And as you know from your experience, it's very common to throw in must speak English, and that has consequences, and those consequences are not good for some groups who have great potential to benefit from some of the things that are being tested. So I think the things which might help stop that, and I have something on undergraduates too in a moment, but are we would want funders to ask if it gets to the funder and there's that criterion must speak English, then the funder needs to push back the review process, push back and say why, given what you've told us about who has the condition. If it gets past the funder, then ethics needs to say but why, or the Health Research Authority needs to say but why, or the MHRA. So there are multiple points at which it can be stopped, so that it becomes much harder for it to just be waved through, which I think has largely been the case, as is your experience. It all just gets waved through and accepted, but it has consequences, and that particular criterion is very common, and we do need to stop and really put people on the spot about that. Your point about training undergraduates is very well made, and there's a group called the Trial Methodology Research Partnership Inclusivity Subgroup. Again, Shob is part of that, and probably a year, maybe even 2 years ago, one of the things that group said was we need to develop some a sort of curriculum, if you like, for training undergraduate medical students or health professionals, biomedical students in inclusive research design. And that led to a project which has actually now been funded by the EU, which has just started, which would develop an undergraduate curriculum on inclusive research design, plus some professional training, all of which will be made freely available when it's finished. So that would, again, be one of the things that you're asking for, and we would agree with it, is that we have to think about what we're telling students right at the start of their career. Otherwise, why would they suddenly stop doing it if when they were trained, nobody raised it, and we want to raise it at training. So undergraduate training, PhDs, master's training, all of these, we need to be banging this particular drum about inclusive design.
Thank you.
I've got a question in the back here.
Hello, thank you. I'm a PPI contributor. I'm a co-applicant for a trial, but I was brought in at rather a late stage. But more importantly, I sit on the grants panel for a major charity that commissions and gives grants for research. And the quality of PPI at the design stage is very much a key consideration on which applications can stand or fall. So I was interested that only came in at the very end of your talk. And I wondered whether you think there should be PPI involvement in the completion of the Include questionnaires.
Yes, very much so. And actually on the questionnaires, it says that. So at the beginning of them, there's a bit of guidance about who we think should be doing it. And that should involve public contributors and other people who have a role to play in the trial. So The example I mentioned that Shoba helped us with some years ago, linked to in vitro fertilization, that piece of PPI work was done as part of the process of completing an include ethnicity framework for that trial. And we, in the framework itself, we are clear that it's very, very hard to do the job well without involving people who represent the people you're trying to include in your trial or think you need to include. So PPI. So you're 100% correct. Those forms should be completed together with public contributors who are like the people you want to involve in the trial.
Yeah.
Any more questions for Shaun?
Hi, Shaun. Thanks very much. The trials that I work on mainly involve people who have psychosis, and our route for recruiting participants tends to be relying on referrals from secondary mental health care teams. You said a bit about how if there's a sort of lack of diversity in the people who are using the services, then that's obviously going to be reflected in the people who are participating in the trials. I was just wondering, if you have what thoughts you have on how that might be addressed. Because I'm thinking in our case, we have tried to seek self-referrals as an alternative to that, to try to get around the issue of people not being told about opportunities. But so far, it hasn't really been very effective, and we've hardly recruited anyone via that method.
Yeah, so I guess the first thing, which is a significant step forward, would be to recognise the potential for it being a problem. So at the very least, what I think it puts us in a position to do is say at the end of the trial, so even if you only use referrals from the mental health service, for example, that at the end of the trial, when interpreting the findings, you can bring out the applicability implications of having used that referral route and only having the option of using that referral route, for example. So I think that is still progress, because one of our great fears within Trial Forge, I guess, is that we think we have sorted something when we haven't. Like we've got something that is effective, but it's effective for whom? And what you'd be able to do if you recognize that, well, that referral route has implications, is at the end you could say, well, this works for those individuals who are referred through that referral route. What we know about that referral route is that the people who come to us look like this. Other data suggests that the people who have the condition look like this, and there's a difference. These are the implications for that difference. Filling the gap while designing the trial, I think, is then tricky. And that brings us back to what one of your colleagues was mentioned earlier about trust, what is it that means that some individuals who have the condition are not being referred? And why is it that is the case? What's happening? And that might actually be a larger challenge or a different challenge to running that particular trial. Like, what is it about the referral service that is, we think, bringing some inequality with regard to referrals that we would not expect given the disease itself? And that might be worth investigation in its own right. If there were options for other referral routes, as you say, you could explore those. But I imagine without that sort of working with organizations who have trust already, that is likely to be tricky, but not impossible. So I think you'd think, okay, well, this is a problem. These individuals, for whatever reason, are, for example, not engaging with mental health services and therefore cannot get referred because they're not engaging. Why is that? Who else could we perhaps work with? Which other organizations do they work with, if any? And could we therefore tap into them as a way of being able to engage individuals? And we would benefit from the trust that individuals, potential participants, have with those organizations, even though they're not using the health service that many of us do. So I think it is, as you found, tricky, and I don't think that reflects badly on you at all. This is hard. I think this is a very different way of working to how we have in the past, and we don't have easy solutions. But I think the one thing, even if it was completely impossible within the context of a particular trial to change to a range of recruitment routes, for example, it would at the very least enable you to say something at the end with regard to applicability, a more measured interpretation as to whom these results apply. And I think that's in itself an important step forward.
Thank you.
And then our final question.
Thank you for a great talk and for great work on something that feels really pragmatic and useful. You said at the start that a lot of this was focused around trials, and I guess I wanted to open up the conversation to other types of research, because a lot of the research in our group is at a slightly earlier stage, so earlier in kind of the translational identifying or understanding treatments. And all of this feels equally important there, but it feels slightly more challenging because it's often smaller studies. So a lot of our research is maybe 1 or 2 researchers, maybe a PhD student on their own, doing a study with not much funding over quite a short time pressure. And so things like opening it up to avoid those language restrictions feel equally as important for all this research, but I feel very stuck on how I would recommend that a PhD student on their own could make the research more inclusive. And I guess I was just interested in any thoughts you had on how we apply these same standards or values to research of all types, whether there is do we adjust the standards slightly? How do we get around those kind of problems when there is a smaller resource available?
Yeah, so I think that a little bit related to the last question, I think it would be progress to be explicit about the limitations of not being able to do something. So that by not being able to do X, or with the funding that's available or the time that's available, resources, that we have made a decision to do this, that a careful use of that information in the interpretation, so that the consequences of that on interpretation are clear. I think that is progress, in the sense that it may say that we have found that this looks promising, but we have only been able to involve individuals who have a high proficiency in English. What that means is that, given that the disease area has 22% of individuals who are come from immigrant populations and have language issues, it means we are unable to say with any confidence whether this would be useful for them, and that requires further work. So you put limits, I think, on the interpretation of your findings, and I think that is very important, because that isn't something we see, I don't think, very often. So one other type of research where we are doing some work is on evidence synthesis, where we would look across bunches of trials and try and say something about equity, diversity, inclusion, and the limits on applicability that there may need to be highlighted because of who is in the trials included within that systematic review, so that interpretation is better. And of course, at the systematic review stage, we're not doing anything about the design. We're not changing the designs at all. We can't. All we're doing is interpreting the results more appropriately, so that decision makers can use those results more carefully, or it's more obvious to them that, okay, there are some limitations. So I think that is a step forward, even if it's not possible to make the changes that you'd like to. But I think it's important to go into it knowing that by making that design decision, for example, the one you highlighted, we're only going to engage individuals who have high proficiency in English. By making that design decision, these are the consequences. This is what limits how our interpretation will be limited. And that is progress, I think, even if you're unable to change. And you might, in some cases, be able to change, or at least move a little bit closer to what you'd like to do, had you got the time and resources that you really want to be able to do it. So I think going with eyes open is the big piece of progress, even if we had no more money to actually make changes that we'd like to make.
Thank you.
Angeline.
Oh, is this the-
Yeah,
Oh,
we could take a very short question with a very short answer if you're willing,
Oh.
Shaun.
So I just.
Okay, let's try a short one, yeah.
Oh, I'm very happy, thank you. So Shaun, I'm Anjali and I work at the Oxford BRC and help to do some training, and I'm just really interested about the last speaker's question, because one of the things we do is a lot of training around patient and public involvement. For quite often we have people who are at very early stage research, so PhDs, that kind of thing. So they are very much on their own. So I had been thinking, and I just want to check this out with you, that you know, that the Include toolkit is very, very applicable to PhD researchers and early career. You know, you wouldn't have people sort of the great team sitting behind you, but even those 4 questions are, I mean, I'm not saying even, I mean, those 4 questions are a really good starting point, even if you're not able to fully fill them out. There are some really good worked examples within on the Trial Forge website. So I was rather naively assuming that I could be dishing out the contact of the website to all these lovely researchers that we train, and that they'd all go, brilliant, thank you very much. So I just want to check that out with 2 people. I want to triangulate it whilst I'm in the room. So yeah, so
100% fine from.
Oh, good. All right, marvelous. So
Yeah, no. As I mentioned, we don't have. Here is the evidence-informed, gold standard way in which these tools can be used to support inclusive design. We don't have that. We have some tools which have promise. People like some aspects of it, maybe don't like some of the other bits of it. But at this stage, I think any way in which they can be used to improve design decision making with regard to inclusion is worth doing. And as you say, if it's looking at the 4 questions as a PhD student and they otherwise would not have considered those questions, that's a win, I think. So I think it is great that you're using it in the way that you suggest. I think that will bring benefits, but we need evaluation.
Great, thank you. Yeah, and Shaun, just want to say a massive thank you for your expertise and knowledge and being with us today, and like your clear commitment to this work as well. Wonder if we can give Shaun like a big round of applause.
Thank you.
So we're just moving to our lunch break now.